Okay, so welcome everyone to this new meeting, TeDCog meeting. Today's guest, well, internal guest, is Dawn. For those who do not know her, she's well, an experimental psychologist, I guess, with an interest in behavioral science. And she's also one of the main researchers on working on the JITSUVAX project, which is one of the main projects here in TeDCog group. And well, I'm sure she will do a better job in describing what the current stages, are and the project itself. So, Dawn, I'll leave it to you.
Yeah, great, thanks. So let me get the slides up. That hopefully is all working. Right, sorry, my computer's frozen for a sec. Just give it a minute. Okay, great. Just shout if something doesn't turn up, because now I can't see your people for some reason. So yeah, I'm Dawn. I'm a senior research associate in the university, and I am basically the person at Bristol who's sort of in charge of driving the JITSUVAX project forward. And so I'm going to tell you a bit about the project and what we've worked on. And it's actually a preview of a seminar I'm going to be giving to the wider school in Bristol seminar series next month. So you're kind of getting a sneak peek. And I'm also very keen for feedback to make this presentation better when I have to give it in front of the whole school next month. Okay, so well, JITSUVAX is another of the umbrella of TeDCog projects here at Bristol in Steve's lab. And my slides aren't working. Okay, right. It's a project that's funded by the EU's Horizon 2020 program. And there's 6 countries involved with 7 institutions, as you can see from very many number of faces there. It's a huge team of people, and we're all headed up by Steve. And so when I start talking to people about JITSUVAX, they usually go, "Oh, okay, vaccine communication. Is it about the COVID vaccine?" And yes and no. It's looking at the time frame. It's a project that ran from 2021, and it's still going to go until 2025. You do quickly jump to COVID. But actually, vaccine hesitancy is a problem that's been around for long before the pandemic hit. In 2019, the World Health Organization had already identified vaccine hesitancy as one of the top 10 threats to global health. And something that we know about vaccine hesitancy is that one of the key drivers is misinformation that creates a lot of misconceptions about vaccines. And this all has a cost. So COVID actually is an excellent example, just illustrating these costs. So this is research from Canada, which estimated that vaccine hesitancy that was fueled by misinformation, so contributed to over 2 million people in Canada delaying or refusing vaccination. And the associated health cost of this vaccine hesitancy that was fueled by misinformation, they calculated it to be about worth 200,000 COVID cases. And of course, that translates into hospitalizations and ICU patients. And of course, let's say these people hadn't been believing the misinformation and get hesitant to get the vaccines, there would have been fewer deaths. And the total number they put on this in terms of economic costs was nearly 300 million Canadian dollars. So there is a strong cost to this. So what we're interested in as psychologists is how misinformation manages to persuade people to delay or avoid vaccination. So what we know is that it primarily targets the psychological antecedents of vaccination behaviors. And so what I mean by that is that misinformation influences what people know about vaccines. So knowledge, people get inaccurate knowledge, they get misconceptions about vaccines. It also generates negative attitudes towards vaccines, and all of this contributes to people's intentions. So in the context of something like vaccination, where you actually need to go out and do something, those intentions are quite a strong predictor of what you actually then go on to do, your actual behavior. And I talked about misinformation persuading people. I use this word persuade because what we find in research is that misinformation tends to be designed to be persuasive right from the source. And this is the case across a wide range of health misinformation. So there was a meta-analysis that showed that misinformation generally has a lot of misleading rhetoric, and that seems very reasonable at the surface level. It maybe builds on a grain of truth, but that all makes it very hard to correct. So as some examples, it might rely on logical fallacies. So logic that seems very intuitive, but is actually false. It may reference conspiracy theories, just playing on people's insecurities about the world, especially when things are very uncertain. Sometimes it also, well, often it references fake experts, so it sounds very authoritative, although it's not. And the other thing about misinformation is that we have to consider where it's spreading, and one of those platforms is social media. And so this is an analysis I'm showing here that was also done before the pandemic. And this research by Johnson et al., what they did was to map the vaccination views of people having discussions on Facebook, well, discussions about vaccines on Facebook. And so you can see little dots in different colors there. So the blue dots are people having pro-vaccination views and discussing this on Facebook. The red dots are people with anti-vaccination views that they're expressing on Facebook. And of course, you can see that actually most people are displayed in green. That's the majority of people who are just kind of undecided when it comes to vaccination. So there's a lot more people on the fence. The good news is there's a lot more pro-vaccination people than anti-vaccination, about 2.7 million more. But the thing that's worrying isn't the exact numbers, but how they tend to cluster. So you can also see that there's a red camp and a blue camp. So not too surprising, the pro-vaxxers don't seem to be talking to the anti-vaxxers. Clearly their views clash quite a bit. But what we want to pay attention to is who's talking to the people in the middle, those who are colored in green. And what this research found was that the pro-vax communities, these discussions, although they outnumbered the anti-vax ones, they tended to be more isolated. And the anti-vax communities were the ones who were actually interacting more with those, the green dots there, the undecided people. And of course, that's not a good sign, since we know that vaccine misinformation is exceedingly anti-vax. So those people on the fence have a greater chance of being exposed to that misinformation that is predominantly trying to persuade them not to have vaccines. And so the bottom line here is that actually we need to be looking at those conversations about vaccines that's predicated on accurate information, and we need to be talking to people across that spectrum of vaccine attitudes, especially those who are having concerns after having interacted with anti-vax people who are having these discussions and spreading misinformation. So when we talk about these discussions, one question we might have is just, well, why don't we just talk about the facts, just put those facts out there? And this is the thing, there actually is a lot of factual evidence out there. I mean, every country has its health authorities. They've got the NHS, they've got the UKHSA, just in the UK alone. There's plenty more sources that I can't think of off the top of my head right now, but there's plenty of authoritative data, verified information out there. And yet that's not quite enough. And two reasons for why that's not enough come from just basic psychology research itself. So the first one is that if people have already encountered the misinformation, and given what the slide I just showed you before, they are very likely to encounter this misinformation just by being on social media. Now, once it's in our heads, it's extremely hard to dislodge. And this is known within cognitive psychology as the continued influence effect. So basically, if you tell people not to believe a myth, it leaves a gap in the memory where you've just said, okay, well, I don't believe that, then what do I believe? And very often that myth is just going to sink right back in. Now, the second reason why just having all the facts and good information out there doesn't work is because sometimes people won't even accept it, because the acceptance of information is driven by people's worldviews. And so this is why you can see some very striking political patterns around vaccine hesitancy. And for example, you see in this chart, this is from the US, where you see Trump voting states, which are the ones in red, they exhibited more hesitancy than the Biden voting states. That the colors always throw me. I have to like reverse it in my head because it's different. It's complete opposite in the UK. And that's quite a nice regression line. I mean, I kind of wish that a lot of my regressions looked like that. But of course, in this case, that's not good news, that pattern of vaccine hesitancy just based on political identity. So I'm giving a very gloomy picture here. It sounds very bleak because I've just said this doesn't work and that doesn't work. But actually, there are things that do work when it comes to misinformation and having conversations and communicating. So let's look at some of those. And I already outlined that facts alone don't work. Now that's half the picture. We do know that if people are open to engaging with evidence, then whatever evidence we do have can be pretty compelling. But sometimes they're not. So what do we do to get them to that stage? Well, sometimes it's because they're stuck on some misinformation. So we know that from debunking misinformation research, there are some best practices that can help. So for example, if people have that misconception in their head, we can use what we call refutation. And I talked before about that myth that might tend to sink right back into our head. Well, if we're able to replace it with a compelling narrative, then we've got a better chance of making that myth, that misinformation, stay out of people's heads. But let's say the problem is acceptance. So if we're not even willing to discuss or listen to the refutation, what can we do then? So when we're talking about just having those initial conversations and that communication with people, we know that then it helps to show empathy. It helps to tailor the way we communicate. And in this sort of space, it's about restoring trust, because often the case is that trust has been already broken. The World Health Organization also identified this, and it highlighted that healthcare professionals are a vital link between the public and vaccinations, because they tend to be trusted sources of information. So being able to have an empathetic conversation with your healthcare professional can be helpful to move someone along to listening to, well, a correction of a misconception, and subsequently discussing facts and evidence. And one last thing we can also do is to target metacognition. So metacognition refers to things like how we think about our thoughts and our beliefs. So for example, the overconfidence that people sometimes have in their attitudinal positions. So some research earlier on in this decade found that asking people to generate a mechanistic explanation shatters their sense of understanding. It's quite strong wording there. And this is an attempt to explain your own logic, just makes that complexity of what's going on more apparent to you. And then that leads to people reducing their assessment of their own understanding. So basically what they're saying there is that if you ask people to explain themselves, it can sometimes make them less confident in what they believe and also less extreme in their attitudes. And so here are a couple of things that could work, and there's research that's been looking at this in different areas of misinformation and some of it in vaccine communication. But another thing we need to consider is that all of these things that work have to be done with worldview consistent messaging. And what I mean here is that we need to understand what's that motivator, or what's driving people's hesitancy. And there's a very nice paper by Matthew Hornsey and Kelly Fielding, who talked about these sorts of psychological motivators, which they called attitude roots. The paper's title is Attitude Roots and Jiu-Jitsu Persuasion. Those of you who are quite sharp-eyed might notice that Jitsu appears in the project JITSUVAX. And yes, that is kind of the approach that's really at the heart of our research project. So what they say is, if people are motivated to reject science, then repeating evidence will have little impact. And that kind of goes back to what I was saying before, but where if people don't want to listen because it's a threat to their identity, we're not going to get through with all the facts and the evidence and the good data. So they go on to explain what attitude roots are. These are the underlying fears, ideologies, worldviews, and identity needs that sustain and motivate specific surface attitudes like climate skepticism and creationism. So this issue of motivated science rejection is bigger than just vaccination. It's about this wider tendency to reject science altogether. And so it is the anti-science attitude that people hear and see, but it is the attitude root, what lies under the surface, that allows the surface attitudes to survive even when they are challenged by evidence. So if we take a look at how this plays out in terms of vaccination, we need to start from what people are telling us. So what's there on the surface? So in our work, we kind of looked at thousands of reasons people give for why they don't want to have a vaccine. We call these arguments, so because there are specific propositions for what's wrong with vaccines. And we try and look for patterns in this data. And what we see is that these different arguments, they tend to cluster. So for example, on the left, you see this cluster of reasons that's related to a fear of suffering adverse effects from medical interventions. Whereas on the right, you've got a very different cluster. And so you can see these are all about conspiracies, talking about microchips, being in cahoots, trying to control. And so this is all sort of motivated by this tendency to believe in conspiracies. And we can conceptualize these reasons that people are expressing as leaves on a tree. And this is why this term attitude roots is really helpful for the conceptualization. Now, imagine people have attitude roots that go below that surface reasons that they're expressing. And those roots, just like tree roots, they're also sustaining those expressed reasons and making it really hard to counter the person's belief system. So I'll talk a little bit about the kind of work that we were doing to look at this in the context of vaccination. Our team did a systematic literature review of different anti-vaccination arguments like the one I showed you on the previous slide. And what we did was to create a taxonomy, or think of it as a hierarchical classification of all the individual arguments that people have come up with over the years. So you see, we start at the bottom where we have individual expressed arguments. To give an example, maybe here are some that people have said about vaccines containing mercury or containing aluminium. And we consider these as variations in the theme around, well, what ingredients are there in vaccines that mean that we shouldn't take them? And here's another example of a set of themes of arguments. So this is about vaccines causing consequences, which people call injuries. And then we cluster these themes under the same driver. So the motivator here is this fear that vaccines are going to cause medical consequences. And so in our research, we distilled down all of those arguments to 11 different attitude roots. So some of them will seem more straightforward to you. Some of them will have strange titles. I'm not going to go through all of these in detail now because there's a lot of things I would really like to cover. But we have a handy website that you can go to if you want to find out more about each of them. And that's on the QR code that you see on the screen. So feel free to take a screenshot if you like.
So Luke has a question.
Oh, yeah, sorry, I can't. Oh, yes.
Yeah, I know. That's why.
Yeah, thank you.
Really sorry, I'll be really quick. Can you have different attitude roots interacting with one another, forming the surface behavioral concern of not having a vaccine, for instance? Can you have, okay, I've got a little bit of medical skepticism, a little bit of distrust in government, and maybe I'm a tiny bit religious, but that's not there's a few different reasons. And how would you solve that?
Yes, so thanks. It's a very good question because that's indeed what we do see. So I've presented this as sort of very distinct just to get it to be able to communicate it conceptually. But it is true that these tend to overlap a lot. Some of them overlap more than others. And one of the things that we've been doing is to look at how certain traits overlap in people. When we break it down, you can actually see sort of, I think it's like 4 or 5 different profiles of people where you have overlaps in these different motivators. So what happens is that you then tend to have a certain set of themes that people express that relate to several different roots at a time. And one of the things that we are currently looking to research is how specific do you have to be when you're talking to people with different attitude roots? If you talk to them and try and speak to a related motivator, does that also work as well as if you target the exact one? Does that answer your question?
Does. That's really, really interesting. I could talk for ages about this, but we'll move on now. But thank you.
You can catch up at the end as well. Okay, so I think on my next slide, yeah. Okay, so we also had a look at how these attitude roots were distributed in different regions of the world. So I think that's a little bit small in the slide. So I'll just say there's 2 main things you can note here, that the attitude roots, which each of which is represented by a different color, they sort of occur in different frequencies. And the patterns are actually broadly similar across the world, except there are certain regions that have spikes in some roots. So for example, there's a big chunk of blue in 2 of the regions, that's Southeast Asia and the sort of Eastern Mediterranean, Middle East, and that dark blue is religious concerns. So that kind of makes a bit of sense. So it's just I mean, this generally is helpful for people who want to look at their own region and say, well, which are most frequently occurring. In the UK, we actually have, I think, 4 big ones, which are distrust, fears, distorted risk perception, and unwarranted beliefs. So that's a little bit about the technicalities of the research that identified the root, that were looking at these roots. I would like to bring us back now to the reason why we actually care about it, because as I've sort of touched on before, they're serving as psychological drivers. They're motivating people's misinformed beliefs against vaccines. And so these motivations actually affect the way that we interpret information that's incoming to us. And we have this tendency to just reject information if we think it's a threat to our attitude roots. So like in the cartoon there, you've got that sense of rejection of, well, there's facts coming, but it doesn't make any sense to me at all because I have a logic that is motivated by my attitude root, and what you're telling me now doesn't fit with my logic. And it's because of this that we need to think about it in the design of our communication. How do we basically align what we're saying to people's attitude roots so we don't get rejected straight out? And previously, on this slide, if I circle back to it now, basically I was talking about worldview consistent messaging, and how we are operationalizing that is to see whether we can align communication to attitude roots. So for the second part of this talk, what I'm going to do is actually look at these 4 different things that I mentioned about what works in terms of communicating around misinformation and also about vaccines. And because the next part of our research was to look at these and try and see how do we piece them together in a way that forms a helpful framework that people can rely on when they're having conversations. And we know those conversations need to happen. We also know that they're happening a lot for healthcare professionals, but healthcare professionals specifically, they don't have enough tools to help them. So I'm going to actually reverse backwards up the list now. There's a reason for that. And I'm going to talk through the principles for each of these different techniques that we're looking at in our research. I'm going to explain how we followed it up as well. And I'm going to start with this targeting of metacognition. Oh, don't know why my facts are coming up black. Okay. Yes, I'll start with the metacognition. So the idea with metacognition and why we want to target that is because we want to try and break that link between people's confidence in their beliefs, between people's sense of understanding of basically how much they think they actually understand things. And this prior research that went before was conducted around political positions. So I've cited here Fernbach et al. Basically, they asked people to explain their political positions as opposed to a control condition that did something else. And what they found, you can see, is that difference there, where when people are asked to explain why they have a certain political position, how much they also judged how much they thought they understood that position. And before the explanation and after the explanation, you can see that significant drop there. And you don't see that in the control condition. And that also translated into a reduction in extremist political attitudes. So people's extremity on their position reduced after having had to explain it in full. So what we were trying to do in our research was to see if we can do the same, but for negative vaccination positions. So the previous research was looking at political positions, but we also know that overconfidence exists in terms of vaccine knowledge as well. So this is research from Motta et al. In 2018, who showed that people who had really low knowledge about vaccination actually tended to express more overconfidence in that knowledge than people who actually knew a lot. So this is kind of like the Dunning-Kruger effect, if you know of that, where people who don't actually know a lot think they know a lot. And indeed, they found the same pattern in terms of how much people had misperceptions of vaccines. So people who had a lot of misperceptions, so that's the high column on the right there, they also tended to have more overconfidence in how much they knew. And all of this overconfidence was also associated with more anti-vaccine policy attitudes. So in our research, we wanted to see, can we reduce that overconfidence and carry it through to a reduction in anti-vaccination beliefs? So the design of our research, quite simple. We had participants rate a number of anti-vaccination arguments before they go into the intervention or the control. And the reason for that pre-test rating is, one, we want to see if it changes if we measure it post-test. But the second thing is because we want to then actually target the anti-vaccination arguments people endorse the most in the intervention. So the control task, quite simple. They do an alternative thing, which is they write about something else or they read something else. And in the intervention, we pick the top 2 or 3 highest endorsed arguments, the things they support the most. And it's 2 to 3 because we did several experiments. So we then asked them to describe all the details about why they hold that position on that particular anti-vaccination argument, and to really explain all of the links, just really explain yourself in detail. And of course, then they do the anti-vaccination argument afterwards. So we have a pre and a post-test measure. And so what we're interested in seeing here is, can giving that explanation reduce people's confidence in their own beliefs? So what I'm going to show you here is a summary of 3 different experiments we did on this. And I'm going to show you the effect sizes. So what that basically means is that any negative effect size means they reduce their belief after going through the experiment. So actually, that's everything on the left of that central blue line is something we want to see. Anything on the right means that they had more, but they basically they became more anti-vax after the experiment, and we kind of don't want to see that. That's not good. And so all these studies are done with participants who, depending on the experiment, they were either unvaccinated for COVID, which in 2022 means they've pretty much held out for a while, or they had non-positive vaccine attitudes. So we pre-selected participants who were already not in favor of vaccination. So you're going to see a green line. That's the participants who had to explain themselves, and the red line will be for the control. And so I'm going to show you the effects across the experiments. So the good news, they're all on the left side of that central blue line, so they kind of reduce their belief in the anti-vaccination argument. That's quite nice. But the problematic thing, as you probably realize, is that there isn't any difference between the intervention and the control condition. So unfortunately, we can't really say that we've had any success in targeting people's metacognitions through explanation, which is quite sad because we thought this was really going to work. And unfortunately, it didn't. We are still not quite sure why people just express less belief over time. Maybe it's this regression to the mean effect, or maybe they're just responding to this idea that, oh, you've asked me twice, that's what you want to see. I mean, generally, these are people who are quite reactive as well, so I don't think that's the case. But maybe just having that question asked twice is already causing them to reflect and think, well, do I really feel that strongly about it? But the explanation isn't doing anything more. So that's a bit of a shame. That didn't really work. But fortunately, there were 3 other things that we knew from past research that could be helpful. And the next thing was this highlighting the effects of empathy and trust and working with healthcare professionals who are incidentally on the front lines of vaccination work. So we looked at what was being done in that space. And basically, a reason for working through healthcare professionals is that they are one of the best messengers about vaccines that are available. They tend to already be trusted in for a lot of the public. In ratings of which groups of people are trusted the most, they always come up tops. As a point of interest, scientists and researchers come second. That's quite nice. And I'll let you guess who comes up at the bottom. But basically, for healthcare professionals, if we can find things that they can use well, that's quite helpful because they have that level of trust. But of course, the flip side is that trust is really important to them as well. So if they're to talk to patients, they want to maintain that trust in their conversations because they fear that if they damage the relationship by having the conversation, well, if they fear that the conversation will damage their relationship with a patient, they might even avoid actually communicating about vaccines, and that's what we don't want. So in this space, there's a technique called motivational interviewing, and this is actually an intervention that's been having promising effects when it comes to building rapport between healthcare professionals and patients when they want patients to change their behaviors. And it's very much based on counseling, this kind of technique. It's actually more commonly used with addiction behaviors, but it's starting to have promising findings when used in the context of vaccine hesitancy. So Arnaud Gagneux is one of the pioneers of this technique, and we've actually worked with him a bit on this part of the research. So the focus of motivational interviewing actually works very well with the attitude route approach that I talked about earlier, because it's prioritizing this sort of listening, this acknowledgement of people's motivations, and it also works through something called affirmation. So this is seeking to validate the person we're talking to. So I'm going to come to this in our research now. We wanted to study basically this process of affirmation and tailored communication. So basically we call this empathetic communication. And so we had a very simple design when we tried to test this. We basically show participants a scenario where a doctor and a patient interact, and then the patients raise the concern that has an anti-vaccination argument. And we also did several experiments on this. In one of them, we even just used participants' own top-rated anti-vaccination arguments, so things we knew they endorsed. So we have a control condition where the doctor gives a very factual response about basically about vaccines being safe and effective. And then in the intervention condition, we test an empathetic response that's tailored to the anti-vaccination argument. And then we have participants rate this conversation. So they rate the doctor and the response given by the doctor. There are several dimensions of these ratings. So to give you a more concrete idea about what that empathetic refutation looks like, this is one example of an anti-vaccination argument that the patient might be bringing up. So they're saying medical authorities are overreacting. Vaccines are being recommended for every minor illness now. And then the doctor starts by offering an affirmation. So this is a way to show empathy, to try and validate why their patient would feel that way. And so you can see here things like, I can see why, and oh yeah, we definitely don't want to. So they're sort of agreeing with where the patient's coming from, and saying that, oh yeah, there are some things that are true about what you're saying here. And then the doctor goes on to offer a more tailored response that really targets that attitude route and directly addresses the concern, to say that, yeah, it's not really about the safety of efficacy that the patient's worried about. They're worried about this overuse of vaccines. So that's just an example of one of the different versions participants could see. And so let's have a look at the results when we do this. So I'm going to show you violin plots on the screen. Let's change the format here. So the violin plots show the distribution of responses across that 1 to 7 scale where participants provide their ratings. The shaded area is basically that distribution. And we have a central line, which is the mean response in that condition, and the gray box that reflects the 95% confidence interval. And so the red shaded area, that's the control condition, where it was a very factual response, and the green shaded area, that's the intervention, the empathetic condition. So I've split the results by participants' opinion of the COVID-19 vaccine opinion, because we already knew these things about the participants ahead of time. So let's start with the group that's positive. So the first thing you notice is that actually there's not a lot of room for improvement with this group, because they're already very supportive of the doctor, even when they're just throwing facts at the patient. So we see a little bit of improvement, but actually, well, not significant. But then again, we're probably not going to be discussing or trying to persuade this group, because they're the ones who probably have already got their vaccines. So that's all right. Then we look at the group that was neutral or didn't want to tell us. So we assume this is kind of like an on the fence group. And we get quite a nice significant effect here, decent effect size. And this group is supporting getting an empathetic response more than the control response. And our biggest effect is actually with the most resistant individuals. So the people who had negative attitudes about the COVID-19 vaccine. And they just supported getting that empathetic response a lot more. So you can see, well, they don't start from a very good position, but we raise them to that sort of average position where people are like, okay, right, I can see this is a bit better. I can be more receptive to this. And it's working best with exactly the individuals that we need to target with this. And I mentioned several dimensions of the ratings. So we also looked at whether the response was compelling for people. Again, we see a very big effect here. So this is a replication of that study. And this time we only looked at unvaccinated individuals. That's why we see the numbers, the control group starting out with very low ratings to start with. We measured trust. So there's a little bit of the plot, basically the trust scale went from 1 to 5. So the plot, when you plot it out all in one, it looks a bit weird. I should probably remove the 6 and the 7. But basically, yes, it increased people's sense of trust in the doctor. And it also increased openness to further information. Although interestingly, we were quite surprised that people were actually fairly much more receptive than they were trusting and or supportive in the first place with the control condition. So it does actually, in a sense, corroborate what we know about healthcare professionals being the people that people are a bit more willing to engage with, even if they're even if in this case they're actually slightly distrustful to begin with. So we know that actually is pretty good evidence that this is working. It's also helping to target various dimensions of people's response to the approach, and helpfully for the healthcare professionals who do care about trust, it does help to build trust as well. So the next piece we wanted to look at was that thing about refutation. We wanted to see how that could be, whether that could generate support and be convincing and also be received well. So we actually saw a little bit of refutation in our previous step, where the doctor in the scenario did actually have a counter argument. So I think that people may have picked up on that. But what we wanted to look at in our research was also just how much of it was down to that affirmation and how much was the structure of the refutation. And so when I talk about refutation structure, it's about whether it contains strategies that help to address misinformation that tends to get stuck in people's heads. And a lot of these strategies were initially tested, not necessarily with vaccines, but just we know that it's when it comes to correcting misconceptions, for example, in terms of science education, students come with certain misconceptions about science, like, for example, what percentage of our brain do we actually use? These sorts of techniques are really helpful at correcting those misconceptions and making it stay, making the factual information stick. And so if we remember this diagram I showed you before of the continued influence effect, we know it's not enough to just say, like, tell people what the facts are and to say that, oh, that misinformation isn't true. We need to fill the space in our brains with an alternative narrative that can stick in there. And how we do that is to make the alternative plausible, keep this correction salient in our response, and really, really explain why that myth is wrong. So we basically went back to that experiment with the doctor and the patient. And this time we were looking more at that separation between having tailored empathetic communication versus just tailored refutation communication. And so again, we were focusing on participants who didn't have positive attitudes towards the COVID vaccine. And so we had people view just one interaction between a doctor and a patient. And again, we had the control and we had the affirmation version. So you've seen this before, but there's a new condition this time where we just had the doctor refute the misconception with a very direct response. So instead of that nice affirmation, that nice empathy, they just go straight in and say that's not true. And then they give the same counter argument that's used in the affirmation condition. So the yellow and the green are using the same counter argument. It's just that one has a affirmation and empathy built in, and the other one's just more direct. And again, people rated these conversations. I'm just going to focus on 2 ratings because, we're might run short of time to go through everything, and everything is pretty similar actually. So we looked at how compelling the doctor's response is and how much people supported that response. So let's look at this question of how compelling the doctor's response is. So I've got the violin plots again, and this is the control condition. And what we found with the just that refutation alone is that having that refutation technique is pretty good. It does make the response more compelling, and that's a significant effect there. It does people acknowledge that, okay, right, that's good logic, that tailored refutation is compelling to me. It actually is even quite comparable to the affirmative version. So we didn't find a significant difference in how compelling people thought those two counter arguments, or well, those two responses were, which is actually good because they are using precisely the same counter arguments. Now, the only issue is when it comes to support, it sort of falls down a bit. So here we get a slightly significant difference between the that direct refutation, so that yellow condition. So that having that refutation structure makes people support it more than just having facts, a very factual approach alone. But it gets a lot less support than when the doctor has that affirmation and empathy as well. So ultimately, the refutation technique, it's logically convincing, but it's not as effective as if you are able to pair it with an affirmation and be empathetic in the communication, because that's what really brings people along with you. So back to our list. So thus far, I've been showing you promising results about pairing empathy and refutation best practice. And we had one last strategy to try, which is facts. And there's actually a lot of research evidence showing that from a public health perspective, like thinking about mass communication about vaccines, providing facts is convincing mainly because it helps to increase people's knowledge about vaccines. So if people are open to engaging with it and they're actually willing to say, okay, I'm going to, find out a bit more, different types of facts are very helpful. So for example, explaining the severity of the disease. In this particular case, in Horn's study, it was about how badly kids could get measles. Cornelia Besch, she looked at the benefits of herd immunity and how, if we really explain how the whole thing works and give sort of illustrated examples, people's vaccine intentions increase. They're also less reactive to vaccine mandates when you actually explain how this whole collective immunity concept works, which is quite interesting as well. Freeman and Joslin, both those studies were looking at the COVID vaccine and factual information provision, and they also find positive effects. In Freeman's case, there was a bit of tailoring to individual groups that was also important. So these were all tested in the mass communication context. Of course, it's a little bit harder to actually go through all of this when you're having a face-to-face conversation. So we tried to simulate it as well in our context. So we sort of built on that doctor-patient scenario and then gave people facts to read to say like, oh, these are the facts that the doctor went through with the patient. And so our data shows you in the red our control condition where they didn't get any factual information at all. And we measured vaccine acceptance scores before and after. So you don't really see any real changes here. It's not significant. And then in blue, you've got people who were shown like, oh, right, the doctor went through these facts. Can you read them and assume that you're in the position of the patient? And so you see a very small effect. It's there, where after reading the facts, you get a little bit more acceptance of vaccines than you did before. So the bottom line here is that compared to not actually giving people facts, those facts are helpful. So we should bear that in mind when we are communicating about vaccines overall. So I'm now going to bring all of that research together about research about what's working and try and talk about how it's sort of led us to try and build a practical tool that we've called the empathetic refutation interview. So we kind of brought it together in a 4-step framework. So to provide a clear conversation goal for people and procedures that can be broken down and explained. And this is really important when you're thinking of trying to tell healthcare professionals, well, how can you approach these conversations? Because they always come and say, well, yeah, okay, great, very interesting research, but what can I do practically? So we wanted to do it in a way where we could say, look, here are the tools you have in your conversation kit. And you might actually, as you might actually see that this actually kind of follows that structure of the 4 different things that we were testing. So basically, we kind of advocate starting a conversation by eliciting concerns. So this is kind of learning from the counseling techniques to build rapport. So for example, you ask open questions that begin with, oh, what do you think? And, oh, why do you think that? Rather than, do you want to do this? Or do you, that sort of question that leads to yes or no answer. There's a lot of active listening to the response. And we also find this a very important step to consider attitude roots, because it's really hard to deal with people's motivations if we don't first listen to what those motivations actually are. And then we're using affirmations. So I talked about the affirmations we tested in our research. This is still coming from the counseling handbook. And basically it's looking to demonstrate empathy, really avoid threatening the person's attitude roots. I gave you an example just now in our experiment, and just showing how much it was meant to validate the individual, acknowledge truths in their beliefs, and just really build that bridge with them. And only when you've done all that do we even start jumping into corrections. So it's important not to jump straight to the correction, but once you do that, you want to target specific myths without trying to challenge and change the whole belief system, because that's the thing that's resistant to change. So we want to use the best practice in refutation technique, explaining why the misconception is wrong, replacing it with a compelling alternative. And to make that alternative compelling, we need to tailor it to people's attitude roots and then try and work with the attitude root to offer a different perspective that still fits within that overall belief system. Basically, we don't want to go hard up against the attitude root system. And finally, we want to provide evidence about vaccination that is easy for people to understand. So we talk here about summarizing complex evidence, using illustrations to help explain. And this is all coming under this final step of providing facts that can help to raise vaccine acceptance. So altogether, it's this process that's really building on the research I talked about thus far, from coming from counseling, coming from mass communications, building on misinformation research. The goal is to tackle trust, to tackle receptivity, but also belief change and vaccine acceptance, all in one conversation framework. And it's specifically tailored for vaccine conversations that healthcare professionals need to have. And that's where the importance of having practical tools comes in, because healthcare professionals are well positioned to have conversations, but they do need that sort of support to be able to structure, how are we doing this? What's the best practice? And because of that, we didn't just end things with the research studies. We are in a phase where we're actually producing training tools and guides like this website. I gave you a preview of it just now when I was talking about the attitude roots. But it's more than just a guide to attitude roots. It's actually a resource that documents all of the attitude roots with guidance on the different ways you can affirm people who hold those attitude roots. And it gives tips for rebutting that uses the refutational best practice that we tested in our research. So what's next for us, or what's currently running for us, is to actually field test practical training packages that's based on the research. So right now, these field tests are running across the various JITSUVAX countries, where we're trying to see how to introduce the empathetic refutational interview in training for healthcare professionals. So we're looking at whether we can develop skills and confidence in the healthcare professionals, but also we're keen to see how they perceive this new approach. So we're kind of doing a very mixed methods approach here, where we're collecting quantitative data from the healthcare professionals, but also doing follow-up interviews with them. And so in the UK at Bristol, we're doing a randomized experiment within the university hospital's existing training programs. So we're comparing this new training with an existing module they already have on debunking myths. And in France, Germany, and Romania, they're sort of looking at training healthcare professionals and comparing that with motivational interviewing training alone. And so all of this is heading towards this final product, which we call a Train the Trainer's Guide to delivering effective vaccine communication training. And that's our big objective that we need to achieve in 2024. And so far, we've trained about 100 healthcare professionals in the UK and 70 in France, and the work is about to kickstart in Germany and Romania. And I'm going to end this presentation on a positive note. So this is, I mentioned Train the Trainers, and we're starting to develop that as well. So this is feedback from a series we just ran last week and the week before in partnership with UKHSA and NHS England. And it's really nice feedback for us. And I'm actually, surprisingly, I'm not even cherry picking. This is, I know it's qualitative data, a small sample, but it was actually representative of all the trainees that we had in the workshop. And it was a surprisingly large proportion of them who actually bothered to write things in the open-ended questions. When you do research, you're always very surprised because you want to avoid open-ended questions because you have to incentivize people to write them. But it's a very nice place for us to be with this research right now. we've done sort of the hard yards in terms of the basic research, and we've got some promising applied value in the product. So it's a very interesting journey for us. Hopefully it's been interesting for all of you to hear about as well. And that is the end. Thank you so much for listening. And also massive thanks to the huge team that is behind it. I think none of them is actually here today, which is a shame, but they all know the research. So I'm glad to be sharing it with a wider audience. Thanks very much.
Thank you, Dawn. Well, Angela is here, so at least.
Oh, right, you popped in when I wasn't looking.
So thank you. I found that very compelling and also very, very clear to follow. So so we do have, well, less than 10 minutes for the questions if you if the audience has any questions.
Yeah, Luke.
Hello again. Sorry. Just very quickly. So you spoke about the attitude roots and how that there can be multiple of them and how they intersect into potentially 5 sort of profiles of patients who are vaccine hesitant. Can they shift over time, and how could healthcare professionals deal with shifts in attitude roots? So, for instance, you start off having fear and phobia, and then over time it shifts into a distrust and a distrust in government, more so than to do with the medical reasons or religious concerns. For example, how would they deal with that?
So that's a very interesting question, because we haven't actually looked at whether people's attitude roots might shift. Now, we suspect that isn't going to be the case, because if you think about it, attitude roots are supposed to be these deep underlying structures. They're part of your personality. They're part of your motivation. So if they were that easy to shift, we wouldn't really have to deal with them at all. They would just be like surface reasons that aren't really rooted, and you can easily change people's minds.
Sure.
However, they can overlap, and sometimes that affects which particular arguments someone might bring to the table. And so in our training, we do kind of try and develop techniques to deal with it, where what if somebody is bombarding you with different things, like first it's a conspiracy theory, and then after that it's something to do with fears, and then suddenly it's a religious reason. So some of the techniques we're teaching is sort of, well, bring it back to the first 2 steps and say, okay, well, what do you think is the most important? What shall we deal with now? And I think it's a very challenging space when you're having those conversations. I mean, I can say I'm doing this research, but I struggle with it myself if I suddenly come up with somebody who starts going off about vaccines, and it does happen. So yeah, it can be difficult, but I mean, maybe Angelo can even say a bit more, because he's kind of the personality expert. But my intuition is that it wouldn't change over time, because otherwise it wouldn't really be the deep motivator.
The only reason why I ask is actually from personal experience, and I'm not going to start going off on vaccines, because I've changed a lot since then. But in COVID, I didn't actually have one COVID vaccine, and it stemmed from when I was 16. I took part in a meningitis B vaccine trial, and I had serious myocarditis as a adverse reaction to it. So when the COVID vaccines came out, I went to the GP, and he said, potentially on medical grounds, it's probably not great, but I'll refer you to a cardiologist. Went to the cardiologist, and they said it'd be fine to have the vaccine. But I was so hesitant, because I'd already got this confirmation bias from my GP that I shouldn't potentially have the vaccine, that I didn't get it. And then over time, my distrust in government increased, and I'd say it probably went from a medical route into more of a distrust in medical practitioners and the government route. That's all. The only reason why I ask is from personal experience, but maybe that's not the underlying root cause. Who knows? But yeah.
No, I mean, I think sometimes it is that both are there, and it's important to know that actually most of us don't know our attitude roots so well. It's not like I don't think anyone really spends a lot of time thinking, right, what's my deep underlying reasons for things. So sometimes all of it is there, and it just sort of expresses itself differently. But I will say, actually, I think that, if a recommendation from your GP that you should be careful and prior experiences, that is actually a legitimate reason to
Yeah,
be
it was.
wary.
It was, but then I suppose with the vaccine mandates and coming in and all of the rhetoric around the news around potentially vaccine passports coming in, and people just, I felt a little bit ostracized because everybody who I spoke to about vaccines were very pro-vaccine, and they didn't like the fact that I was unvaccinated, even for medical reasons. And that made me more distrustful in the whole system around it. So I don't know whether or not it grew out of that, and potentially just, bad education around how to deal with vaccine hesitancy. Who knows? But just thought it's interesting. So I just wanted to learn a bit more.
I mean, now I'm quite curious as to if you had got sort of like open questions and affirmations of how you felt.
No, I really didn't. I really didn't. My GP was like, yeah, no, after the whole myocarditis and pericarditis thing, because I looked up, there was a CDC report and it was really early days in terms of the research, and there wasn't a lot known, and it was just that there was a few cases of people getting myocarditis, and I was like, oh, best not. But then actually it turns out you're more likely to get myocarditis from contracting COVID-19 than the actual vaccine. So in hindsight, it was completely unbased, my fear. But by that point, my distrust had solidified so much that I wasn't going to get a vaccine.
Yeah.
I didn't get any open-ended questions, any affirmations. It was just they did a scan on my heart, and the consultant was like, yeah, you can have the vaccine. There wasn't really anything to address the underlying belief roots.
Yeah, maybe I can say something about that. Your situation is very interesting because you have two routes, and something that I think is not reflected in the online experiments is the fact that conversations tend to evolve, and something important that we remark in the training is that the conversation must evolve to find the most important route. Because people, there are many components. There are affective components, there are cognitive components, and many times people rationalize their affective components, their fear, with a conspiracy theory. But the important thing is the fear, and the conspiracy theory is a tool to try to stabilize the dissonance and try to rationalize the fear and so on. So yes, I mean, in your case, I mean, you need to have a long conversation and talk about everything and your fears, also your beliefs, your distrust. I mean, it needs a lot of empathy and skills from the HEP.
Cool. Thank you.
Costas.
Yeah, sorry, there's a question from Costas. It's been like, then we have maybe like dozens of seconds left. Is it like quick enough or?
Yeah, I don't know. So I will.
Well, I
let
the meeting flow. So anyone that has to go, like, please lead. So
yeah. So when I have discussed with friends outside of academia about our attitude towards facilitating vaccination and reducing vaccine hesitance, one of the most interesting comments that I have received is, how certain are you? You know, like as scientists, as behavioral scientists that advocate in favor of vaccine taking and against vaccine hesitance, and how certain are we in every case? And I'm worried that sometimes by being anxious about supporting the noble cause, we might be creating some kind of distorted view of reality. Because, for example, we know that well-established vaccines do an amazing good job in many things, but this does not mean that we should generalize over all vaccines, even the ones that are just now being developed, right? So I wonder, in this approach that you are doing with the empathetic one, does this also come into play to reduce this kind of communicated certainty about these things? Or is it, no, we are certain, we're just communicating differently because you are not ready to receive this kind of information otherwise?
So when you say certainty, what certainty are we talking about here?
So, for example, when we were at the initial steps with COVID-19, we had 3-4 types of vaccines that were being developed, and we were advocating in favor of getting any vaccine, right? And we were saying any vaccine is better than no vaccine. However, when the what was the name of it? The one that was developed in the UK, the AstraZeneca. When the AstraZeneca whole mess came about, it created a lot of controversy with people because it was clear that they had not been completely transparent about their whole process. So we were advocating in favor of AstraZeneca, for example, while we didn't have the full information. So that's what I mean, that in some cases, we know exactly that a vaccine has been used for 30, 40 years and has great benefits. But in other cases, we are not that sure. We trust, in a way, other scientists that they are being honest with us.
Yes, and actually, so that's the thing where I look at that and go, yeah, we can definitely agree that the lack of transparency or not having the full information was problematic. But that is a different issue from whether we are certain that actually the vaccine, compared to the risks of the disease, is beneficial. Because, do you see what I mean? Like, yes, maybe we're not comparing the vaccine for measles versus the vaccine for COVID. We're comparing the vaccine for COVID with COVID, and it's a very different proposition. Does that make any sense, or am I going off?
No, yeah, it makes sense. And as I said, it's a big topic of discussion, in a more general topic of discussion. The degree of certainty with which we communicate as if we are the bearers of the ultimate truth, which is something that a lot of people have an aversion towards.
Yeah.
You know, when you come from above and say, we are the scientists and we tell you what is the truth. And many people don't like this.
Yeah.
You know?
Yeah, I think that does change a bit with this approach, because it sort of puts you more on even footing. And I think sometimes a lot of when I start talking about this approach in the training sessions, some of the aversion I get is when I tell people we should acknowledge the truth in what people are saying. And that sort of messes up with people who are very certain about vaccines sometimes, because it's really hard to then go like, but what truth are they talking about? Whereas if you actually start saying like, oh, actually, this bit of what you're saying is true, if you can actually bring yourself to that position to realize, hang on, it's not all wrong. Maybe the conclusion is false, but there's some logic in there that makes sense. And we need to engage with that first, because once you say, no, that's all false, that's all misinformation, people can legitimately go there and say, well, but that bit I know is definitely true. You like that. I don't know what's the. So let's say that they're worried that the COVID vaccine has a microchip. Now that's a really hard one to agree with, because the underlying concern is that people are going to get microchipped, and actually that's not an unfair concern looking at how technology is going. And so agreeing that this is something we need to be concerned about and wary about is very different from saying agreeing that the COVID vaccine has the microchip. We can actually agree that, yeah, let's make sure we don't get microchipped, and then go on to say, right, but let's look at this bit. Do we think it's in the COVID vaccine, or is it more likely it's going to come from another source that we need to be alert from? And is worrying about the microchip in the COVID vaccine then distracting you from actually looking for the real microchip?
Yes. Yeah, I completely agree. Yeah.
Yeah.
Okay, we have 5. Yeah, there's 5 past 2, so I think maybe we could wrap it up. And it was very interesting again, and thank you very much for staying a bit. And so Dawn, if you don't have anything to add, I think that we'll see each other next week. We will have our first external guest, yeah, looking forward to have all of you like here. Okay. So thank you very much. Have a nice weekend. Bye-bye.
Bye.